So my name's Todd Brown. I'm an endocrinologist at Johns Hopkins, and I've been working for about 20 years in the area of metabolic and endocrine complications in HIV infection. And one of the areas that I've been very interested in is bone disease and fracture risk. And so I'll be talking today about more of a practical meet the professor kind of thing about bones in HIV and how to evaluate bones and you know, some of the nuances that you might run into when you are seeing patients in clinic. And so this is should be an interactive type session. It's always, you know, and I've done these live, it's always a back and forth, and it's actually really fun to do. And I hope to preserve that kind of character in the online, you know, virtual format, which is always tricky. And so a couple things that might facilitate that. You all are familiar, you know, having done millions of Zoom calls in the last, you know, 4 or 5 months, how to work Zoom, but the chat box is going to be great. So if you have questions, you can you put a question in the chat box, and I'll be addressing them. So then the other way is the good old-fashioned speak up kind of thing. And so what I'll be doing is there'll be about a 15-minute presentation. I'll lay out some of the issues about the evaluation of bone and fracture risk in the people living with HIV. And then I have a bunch of cases. So these are cases that people that I've seen or heard in the case of audio, you know, audio only clinic visits in the last month that highlight some of the important issues related to bone disease and people living with HIV. And so I've got 5 of them. I don't need to get through all of them. They're really a springboard for discussion. So what I'm going to do after each segment is pause and then have you all have the opportunity either to ask questions or either verbally, you know, unmute yourself and just go ahead and ask. So I'll pause and say, are there any questions, anyone, and other issues that people want to bring out? Or we can go on to look at the chat to see if there are any questions in the chat. And so I have the chat open so I can see the chat in real time, you know, what you guys are thinking, if you have any questions, comments, etc. One question came up about the slides being available. Yeah, no problem. I'm not sure. We'll have to talk with the IAS folks about how the slides will get to you, if they're going to be on you know, some sort of platform. I'm not sure, but no problem from my perspective, no problem. And I think that IAS is interested in sharing. Okay. So with that said, why don't we go ahead and get started? I will jump in and hopefully be able to navigate through. So here are my disclosures. So the objectives: to understand how best to assess fracture risk in people with HIV, knowing when is appropriate to screen for osteoporosis with DEXA, and how to interpret the DEXA scan results. So I'll show you some printouts of DEXAs and what you should be looking for and what can be sometimes tricky. Understanding the limits of DEXA scans and to be aware of treatments to improve bone health in people with HIV, the risks and benefits, and understanding how to monitor treatment. Okay, so this is the big question. Lots of things to worry about in people living with HIV, or people getting older in general, but in particular people in HIV, since aging-related comorbidities, many of them are higher in frequency in people living with HIV compared to age-matched people without HIV. And so osteoporosis and fracture is one of those things. And so it's very common in people in older populations and people with HIV, and actually more common in those with HIV compared to those without. And importantly, we think of fractures as a problem in terms of morbidity, and decrease in quality of life, but what's less recognized is the effect on mortality. And so the risk of mortality increases greatly after hip fracture, particularly a hip fracture, and doesn't come back down to baseline even 10 years out. And so if we can avoid fractures, we hopefully can bend that trajectory of health span and lifespan upwards, and to really improve quality of life for people with HIV. The other important thing is that it's a silent disease until a fracture occurs. So we have an opportunity to prevent the outcome, which is fracture, and we can detect it given with good screening tools. And we've been talking a lot about DEXA, and so we can find people who are at risk for fracture and intervene on them to prevent fractures. So, so this is my case for why we should care about osteoporosis. But of course, you're thinking, if you're doing primary care, you're thinking about all the other problems that the patient has, right? You're thinking about their heart, and you're thinking about their liver, and you're thinking about their brain and their kidneys, et cetera, not to mention all the psychosocial determinants of health, which are super important to address. And so, so this is my case to say, well, you should worry about bones too. So let's take a step back and say, well, what is osteoporosis anyway? And so this was a definition from the mid-90s that I think is quite useful because it illustrates a couple points. It's a systemic skeletal disorder characterized by two things: so low bone mass and microarchitectural deterioration of bone tissue with a consequent increase in bone fragility and fracture. And so the two things are really important. So low bone mass, so that's picked up by DEXA scan. The microarchitectural deterioration of bone tissue, that's also known as bone quality. And the DEXA scan really doesn't pick that up. And this is one of the limitations. But it's important to think about, and there are other ways that we can assess the microarchitectural deterioration, or at least have some surrogate as to when there's a deficit in bone quality. So to illustrate this, these are some micrographs, and on the left you see normal bone, and on the right you see osteoporotic bone. This is a spine, vertebral process here, and vertebral body, and you see that there's cortical bone, which in the vertebra is a thin sort of ring around the bone, and then in the middle is trabecular bone. And so this is a woven network of bone. And what you see on the left is that the trabeculate's very well ordered. And normally there would be bone marrow in this space. It's a very active kind of place, lots of cells being made there, including blood cells. And on the right, what you see is osteoporotic bone. So there are two things, and this illustrates the 2 points that I was talking about. Not only do you see less bone there, so if you just look at the bone, it's clearly there's less bone on the right than on the left, but the bone is disorganized. And this is this microarchitectural deterioration that I was talking about. And so this is the thing that DEXA doesn't do such a great job in detecting. So here are our operational definitions of osteoporosis. And so we all use DEXA, but we need to recognize its limitations. And so osteoporosis is defined as a T-score less than or equal to 2.5, minus 2.5. And so what that means is that the bone mineral density of your patient is 2.5 standard deviations or more less than a person at their peak bone mass. So this is the T-score compared to someone at their peak bone mass between age 25 and 30. And we'll talk about who that reference population is, because that's actually turns out to be an important issue in how to determine what the T-score is, and using FRAX in particular, which we'll be talking about. Osteopenia is between a T-score of -1 and -2.4. That's 1 to 2.4 standard deviations less than a person at their peak bone mass, and normal is greater than -1. And so importantly, there's a relationship between the DEXA T-score and fracture. There's an increase of about 1.5 to 3 times increased risk of fracture for each standard deviation or T-score decrease in BMD. So there's a good relationship there, but it's not a great relationship. And it's akin to the relationship between hypertension and stroke. So clearly hypertension is a risk factor for stroke, but not all strokes occur in people who have high blood pressure, and all people with hypertension are going to have a stroke, obviously. But there is a relationship there. So a couple caveats. One is that this definition is really for older men, so men greater than 50, and postmenopausal women. For people who are younger, the Z-score should be used. And the Z-score is the reference population is someone who is the same sex and the same age as your patient. And so what we use in that population is a Z-score less than or equal to -2, so 2 standard deviations, less than an age sex matched person. And we would call that person have low bone mineral density. And you really can't say the person has osteoporosis unless in that population, unless they also have an osteoporotic fracture. And so that's really important to keep in mind. And then the other thing, which you probably could guess from what I've said just now, is that bone mineral density by DEXA explains only about half of fracture risk. And so it's a good test, but not a great test. And so there's another 50% that's explained by bone quality measures, if we could measure it well. But also there's other factors that are important with fracture risk, and in particular falls, that aren't obviously accounted for at all by DEXA scanning. And so trying to think globally and holistically about your patient, and to think not only about their bones, but about their fall risk and about other things that may contribute to them having a fracture. Okay. So for those of you who've never seen a DEXA scanner, this is what it looks like. So the person lies down on this table, and the C arm, which is on this scanner, it's a horizon by Hologic. This sort of turns, in 90 degrees and scans the patient. And generally you get 2 scans. One is a scan of the lumbar spine, and that's what this woman is undergoing now. So the legs are up on a block, you can see, and it scans the segment from L1 to L4. The hip scan, the legs are down on the table. There's a little brace that internally rotates the left side usually, and this fixes, holds the leg in place so you can get a good image. And that gives you 2 measurements, and we'll be seeing DEXA reports, and I'll point them out again. That's the femoral neck and the total hip, and I'll tell you what those areas look like. So we have the lumbar spine, typically 3 numbers: the lumbar spine bone density, the femoral neck bone density, and the total hip bone density. Now, there are some, you can also do a forearm bone density. And so when would you want to get that? So we typically get it in a situation where you first, whatever, say instrumentation, say in the spine, someone has spine surgery and you have a lot of hardware there and you can't do a DEXA of the spine, or if you have instrumentation in the hip with hip prior hip surgery, for example. You want to do the forearm. The other situation where it's important to do the forearm is in hyperparathyroidism, so primary hyperparathyroidism. The earliest effects are at the forearm, the distal 1/3 of the forearm. And so in a case of hyperparathyroidism, you want to do the forearm because the person may have normal bone mineral density at the spine and the hip, but they could have terrible bone mineral density at the forearm. And this is the reason being is that the forearm is mostly cortical bone. And this is preferentially affected in hyperparathyroidism. The lumbar spine, I should mention, is about 20% cortical bone. Most of it is trabecular bone, about 80% trabecular bone. And so things like steroids, for example, affect trabecular bone more quickly. And so you'll see deficits in the spine quite quickly. And the hip is about 50-50. So 50% cortical, 50% trabecular. So it's sort of in the middle. So this is the experience that your patient will have when you order a DEXA scan. They'll get a spine DEXA and a hip DEXA. Each of the scans, once the person is positioned, the scan actually takes about 10 seconds. But the positioning can be a little bit tricky. So overall, for the experience, they change into a gown, they get up on the table, the technologist positions the person right. They'll do the scan once to be sure that's positioned. Sometimes they hit it right, sometimes they don't. So the whole process takes about 20 minutes for your patient. Okay, so this is DEXA, and then I'm going to be talking about other modalities to assess fracture risk. And one thing that I've used quite a bit of is spine x-rays, and you'll see this in the cases, where about half of vertebral fractures are clinically silent. And so if your patient has a clinically silent, so-called occult vertebral fracture, that is telling you something about their bones, something about the bones that DEXA may not pick up on. And I'll show you, give you an illustration of this. And so whenever I'm in a situation where I'm not sure to treat or not to treat, their bone density looks pretty good, but maybe in the osteoporotic range, but they don't have lots of other risk factors, the spine x-rays will be very helpful for me to try to further risk stratify. So I just ordered lumbar and thoracic spine x-rays, and you can get a good sense, look and rule out occult vertebral fracture. Very simple, very easy, very cheap, and provides good information. So just to put a finer point on it, this is from an Italian cohort of one cohort, 141 people with HIV in a single cohort. And you can see here on the right, the number of people, so 18 who had BMD in the normal range, osteopenia range, or osteoporotic range. So 18% osteoporosis, lots of osteopenia, and about a third had normal BMD. Okay, so this is sort of typical in your average HIV clinic, you know, where the median age is, say, in the mid-50s. And so what they did is they did plain x-rays on everyone. And this is what the SDI is a measure of the spine deformity index. So this is a measure of a fractured, clinically occult fracture of the spine. So if you have your SDI is greater or equal to 2, then you have an occult vertebral fracture. So what they found is that about 15% of this group had an occult spine fracture. And so that's important. So it's a decent chunk, and that's about on with other cohorts. Somewhere around 20% will have an occult vertebral fracture. And if you look at the distribution of osteopenia, osteoporosis, what you see is that if you the yellow is the osteoporosis. But what I want to draw your attention to is this tan or rust color bar and the red color bar, because these are the people without osteoporosis. And so about a good chunk of these people, about 2/3 of the people who have a subclinical vertebral fracture don't have osteoporosis. So here you really can get a sense of the disconnect between BMD by DEXA and bone fragility by just by the simple vertebral x-ray. And so I really, this is one thing, a take-home message that I think is super important, is use this plain films of the spine when you're evaluating patients, particularly those where you are trying to further put a finer point on their risk assessment. Okay, so that's spine x-rays, and we'll be talking more about those in the cases. So the next thing is trabecular bone score. And so this is a sort of a new kid on the block. In the last 6-7 years, this has emerged as potentially a helpful kind of tool. So this is actually data that's derived from the DEXA scanner. And you can, if the DEXA machine has the software, all the technologist needs to do is press TBS and it generates this score. And so what this does is takes the image from the X-ray, from the DEXA scan rather, and this is, well, I'll show you a picture in a second, but you can see here what it looks like. And it makes the TBS makes what they call a variogram of the trabeculae for the spine. And so here you can see normal, healthy bone. You can see there's variation in the bone. There's places where there is bone. There are places where there isn't bone. And that has a relatively high TBS. With osteoporosis, as I showed you in the picture before, you have this destruction of bone. There's less bone there, and there's variation in the bone. And this is picked up with TBS with a relatively low TBS value. And these are the cut points that have been set out. The important thing is that this, in epidemiologic studies, has been shown to contribute to fracture risk independent of bone mineral density, independent of conventional bone mineral density. And so this can be helpful to further risk stratify, but it all depends on whether the TBS software is installed on your DEXA machine. So you can put in your comments, add TBS if possible, and then you'll get a TBS value as well. And then importantly, we'll be talking about FRAX in a second, but the FRAX, which is a quantitative assessment of people's clinical risk of fracture, they can adjust for trabecular bone score to further refine that 10-year risk of fracture. We'll see that in a second. Okay, the other thing that I alluded to earlier when we're thinking about assessing fracture risk is fall risk. And so if we can prevent falls, we can do a good job at preventing fractures. And the question that I often ask patients are if they've fallen in the last 6 months, and then importantly, if they're worried about falling. So it turns out that if people are worried about falling, then they're really at a very high risk of fracture. It's a good way to open the conversation up about falls. The importance here is that if you do identify someone who's at risk for falling, you can send them for physical therapy, for strength and balance training. And it's also important to open the door talking about environmental things that could be modified and behavioral things that could be modified. So environmental things like keeping lights on, avoiding loose rugs, avoiding clutter on the floor, keeping wires behind furniture. Behavioral assessment and modification as far as avoiding alcohol and drugs, sturdy shoes, avoiding slippery surfaces. So all these simple things may be helpful in keeping patients on their feet. So the other, what's emerged as a really important tool is the clinical risk factor assessment. In the last 20 years or so, 15 years or so, there's been an effort to develop a 10-year risk equation, similar to the Framingham equation for cardiovascular disease. And so instead of using a DEXA only approach where you're only making a decision about the bones, whether it's treatment or risk stratification based on the bone density, here you're using several risk factors that play into a person's fracture risk. And you can generate a 10-year risk of a osteoporotic fracture, and that's a fracture in the hip, in the spine, in the upper arm, or in the wrist, or a hip fracture per se. And so we'll be talking about the threshold. So for those of you who haven't used the FRAX equation, it's very easy to use. You can Google FRAX or whatever web browser you use and put in FRAX. You come up to this page in Sheffield, England. You go under calculation tool and choose your country and choose your population, and population meaning ethnicity. And so this person I chose the US, and you can see the flag there, and the person is Black. So then you would fill in the various information. If you can't get the person's weight in kilograms and centimeters, you can convert over here. You toggle on these the various risk factors. These are risk factors that are independent of bone mineral density that will increase fracture risk. And then you put in the femoral neck bone mineral density. And you can either put in the bone mineral density from the number that comes out of the scan, or you can put in the T-score. So you select which one you're going to do, and then you calculate it, and you get a value. So the important thing here is that similar to the Framingham risk equation in people with HIV, which underestimates the risk of cardiovascular disease or cardiovascular events, the FRAX also underestimates fracture risk in people living with HIV. And so how much to correct it up hasn't really been completely determined. But you should know that whatever FRAX you get might be a little bit lower than their actual risk. And so that's important to keep in mind. You know, you can think of, well, should I bump, if the person has HIV, how much should I bump it up by? Should I make, if a 55-year-old, should I bump it up by, give them 10 years, for example, and would that better approximate the risk? So it's unclear exactly how to do this so it gives you a better result. The secondary osteoporosis button, you'll see number 10 here, is a tempting way to do it, but it really only works. It really only moves FRAX when you do the FRAX without bone mineral density. And so if you're doing it like you do FRAX without bone mineral density, say if you're in the UK and you don't have access to DEXA scans, that might be a helpful tool, but it doesn't really help if you have the bone mineral density already. But it's something to keep in mind. So one issue is to screen or not to screen. and here is the National Osteoporosis Foundation screening guidelines. So we want to do DEXA screening in people with fragility fracture, and women 65 and older, or men 70 or older. Or if you have a younger postmenopausal woman and a man between 50 and 69 with clinical risk factors for fracture. So if you look at the document, there's all kinds of risk factors for fracture. As of about 2013, HIV and antiretroviral therapy has been on that list. So it shouldn't be a problem for you to get this covered by insurance, because it is screening a person, a 50-year-old male and above, or a postmenopausal woman with HIV is indeed clinically indicated. And you could also use this last criteria, condition or taking medication associated with low bone mass or bone loss. And this is true of both HIV and antiretroviral therapy. And so this is, we did some guidelines, recommendations a few years ago, and this is sort of what we came up with in terms of screening recommendations based on the NOF guidelines, screening postmenopausal women with HIV and men 50 and older. NOF guidelines on who to treat. So in the US, we treat people with a history of hip or vertebral fractures. Those people have already declared themselves regardless of their bone mineral density. Those with bone mineral density in the osteoporotic range, and I'll show you some potential exceptions here. And then it's really in the osteopenia range where we use FRAX to try to further risk stratify. And so here's the FRAX again. If you put in this person's risk score, they have a T-score of -2.3, which is in the osteopenia range. But on the if you look at their 10-year risk, their risk of major fracture is 18%, so that's less than the 20% threshold. But the hip fracture is greater than is 4%, so that's above the threshold, 4.1. So that's above the threshold where you would treat. Okay, so let's talk a little bit about some management options before we get into the cases. So general recommendations: calcium and vitamin D. So calcium, generally you want to give dietary calcium if you can. There's this question about calcium supplementation in cardiovascular disease. So generally the recommended approach is to assess how much calcium they get in their diet, and then make up the amount up to about 1,000 or 1,200 milligrams with supplemental calcium. So for most people, this is about 500 milligrams of, say, Oscal or Caltrate. Vitamin D, I generally supplement about 1,000 milligrams. I do check vitamin D levels to be sure that the person doesn't have secondary hyperparathyroidism. If they do have a very low vitamin D level and a very high parathyroid hormone level, particularly if their alkaline phosphatase is high, I would replace them with vitamin D and wait before I start them on bone-specific medication. This is because very severe cases of vitamin D are osteomalacia, not osteoporosis, and you can, by replacing vitamin D, giving them back calcium, you can remineralize their bone, and that bone mineral density can increase. Smoking cessation is really important. Alcohol reduction, both of these are independent risk factors. Weight-bearing exercise, of course. So regarding treatments, so that we generally think about treatments in terms of anti-resorptive treatments and anabolic treatments. And so most of our treatments are anti-resorptive treatments. Bisphosphonates are first-line drugs, and these potently affect osteoclast resorption. And so you can either give it orally as alendronate, for example, that's used most often, or IV yearly zoledronic acid. The bisphosphonates, the big issue for the oral bisphosphonates are GI upset. For IV bisphosphonates, it's really about 30% of people after the first dose get a flu-like condition. And so you need to just warn people that they're going to feel it after their first dose. It's really rare after their second dose or their third dose. For denosumab, this is also a very potent anti-resorptive. It's given as an IV or a sub-Q injection every 6 months, and it's a monoclonal antibody to rank ligand. So the OPG rank ligand system coordinates the osteoblasts, which lay down the bone, and the osteoclasts, which resorb the bone. And so this really poison or decreases the osteoclast activity and has a very potent anti-resorptive effect. Both of these, because they're anti-resorptives, they both have this risk of osteonecrosis of the jaw. So this is a death of the jawbone, and atypical femoral fractures. Atypical femoral fractures are fractures that are below the area of the lesser trochanter. And both are very, very rare. So about a few in 100,000. But things that we need to be thinking about. And because of the osteonecrosis of the jaw and the atypical femoral fractures, there's a lot of concern about bisphosphonate use and actually underuse of these drugs, even in people with high fracture risk. And so, so it's important that we give these drugs to people who will benefit from them. The other thing we need to know about with anti-resorptives and to reduce the risk of osteonecrosis of the jaw is to give them to be sure that people have gotten any invasive dental work done, make sure it's healed before you start these medications. So I always ask about if they've seen their dentist and whether or not they're planning any invasive dental work. Prior invasive dental work is one of the big risk factors for osteonecrosis of the jaw. So other approaches, so selective estrogen receptor modulator, so raloxifene can be used in women. It is a decent drug. It has never been shown to prevent hip fracture or non-vertebral fracture, so it's a little bit of a wimpier drug. Estrogen itself can be used in women who have vasomotor symptoms as well. On the anabolic side, PTH analogs can be used, so teriparatide and abaloparatide. These drugs will increase bone mineral density, and then after you do an 18 to 24 month course, and then you need to give an anti-resorptive afterward to preserve the gains in bone mineral density that you've gotten. And so these drugs actually are usually sequenced after anti-resorptives just because of insurance reasons. There's some reason to suspect that it might be better to go with an anabolic drug first and then a anti-resorptive, but most insurance companies will not cover that. The newest kid on the block is a sclerostin inhibitor. So sclerostin is a hormone that's produced by the osteocyte. If you recall, the osteocytes are sort of the quarterback of the bone microenvironment, and they control the osteoblasts. And so the osteocyte will release sclerostin to put an inhibition on the osteoblast so it can't lay down bone. And so what this sclerostin inhibitor does is block sclerostin to release to pull the brakes off the osteoblast so it can lay down bone. And so this drug was just approved. It's really approved in people with pretty bad osteoporosis. It's given monthly for a 1-year course. It also has the distinction, in my opinion, to have the name that's the most fun to pronounce of all the drugs. So romosozumab. You'll remember it that way. So we don't treat, previously we've treated people forever with bisphosphonates. And so now there's this question of bisphosphonate holiday, and that's to decrease the risk of, potentially decrease the risk of osteonecrosis of the jaw and atypical femoral fractures. And so typically what we do is we risk stratify, so low risk, moderate risk, and high risk. For people at low risk, it's not a problem to stop. For people at moderate risk, we consider a drug holiday. So that's generally 5 years if you're using alendronate or an oral, and 3 years if you're using zoledronic acid. So giving yearly infusions of Reclast. For people who are at high risk, and generally it says -2.5 here, but most people say it's -3 or -3.5, they probably continue to benefit from prolonged bisphosphonates. And so we'll go over a case now about the holiday and how to think about it. There still are a lot of questions, and this is all, there's no randomized trial data about bisphosphonate holidays, and this is a real problem. So how long do you do a holiday for? How do you monitor? It's generally bone mineral density. What do you do for medications after the holiday? So say if you get decrease in bone mineral density after the holiday, what do you do? So I'm going to pause there. So it's 12:46. We've got 25 minutes left. There's one question that came in about the ABC scale. Yes, definitely. ABC scale, it's a balanced confidence scale that gives you the same information as fear of falling. asking the question in clinic, if you want to do the scale, fine, it's a very good scale. We've done it in research, but asking about if they're afraid of falling can open up the conversation and get you in the same place. So I'm going to pause here and see if anyone has any questions. You can either unmute or ask through the chat.
This is Dr. Cuero from Immokalee, Florida. Can you hear me?
Sure. Yeah, sure.
Yeah, I always have a problem when using the frac stools. We always like these bone mineral density measurements to be congruent. They are often not. And a particular problem I face is when their bone mineral density in the lumbar spine is much lower than like in the hip.
Yeah.
How do you correct for that? Because the frac stools ask you to put in the hip measurement.
That's right. Yeah.
So how do you?
What do you do? Yeah, sure. Yeah, very common problem. There's a formula that you could potentially use that was developed in a Canadian cohort where you use 2/3 of the spine and 1/3 of the hip. 2/3 of the hip and 1/3 of the spine, and do a weighted average of the T-scores to better approximate what the person's fracture risk is. So I do that a little bit. Sometimes I actually calculate it out. Sometimes I eyeball it, but it's definitely a limitation of the fracs because it's not just the hip T-score, it's the femoral neck T-score that it draws upon. So we do see discordance between the hip and the spine, and we'll see some cases like that. So you do have to use your judgment. The other approach, the more conservative approach, is just to put the spine T-score in there, but that will probably overestimate your risk of fracture. But maybe since we know that the fracs tool underestimates the risk of fracture in people with HIV, maybe we'll wind up where we should anyway. So it's a great question, and one that I wrestle with too. So I would probably sort of bump up your frac, whatever fracs is giving you, I would bump that up a little bit. Let's see, a bunch of things came in on the chat. Okay. After replenishing vitamin D, would you repeat the DEXA scan or go ahead and start treatment? Great question. So if the person has severe vitamin D deficiency, and so this is like single-digit vitamin D deficiency with elevated parathyroid hormone and an elevated alkaline phosphatase, this is where the bone density that you see is probably osteomalacia and not osteoporosis. Or there could be, you want to treat the osteomalacia first and then think about their bone. So I've had people whose bone density increases 10% or more, 10, 15% by replacing their vitamin D and giving them calcium back, and they can remineralize. And so that's the group that I think it's important. You do want to be sure to replace vitamin D before starting bisphosphonates, because the bump in bone mineral density that you get with bisphosphonates is better in people who are vitamin D sufficient. And so that's important to think about. Good question. So I have lots of patients worry about long-term TDF use and bone density. Will you ever stray from your recs? Yeah, good question. So would I ever stray from the recs about postmenopausal women, 50 and early signs? So would I screen earlier? And this is important in people with HIV, but it's also important in the context of PrEP as well. People who are taking TDF FTC for PrEP. And so the problem is that we don't really know what to do with low bone density in people who are younger. Age is by far the strongest risk factor for fracture, and it's independent. Some of it's related to bone mineral density, some of it is independent of bone mineral density. And so, I think that just from a public health point of view on who should be screened, I think that age is really the best way to do it. If you have someone who you're worried about, so someone who has falls, other risk factors, so other comorbidities that may be related to fracture, someone who has a family history of fracture, it's reasonable to get bone density in that group of patients. The big question is, if you find osteoporosis or osteopenia, what do you do about it? And generally, this is a group of patients who are at relatively, even if their T-scores are low or Z-scores are low, they're at a low absolute risk of fracture. So sometimes if I find it and I do this, I find this even for myself. When I was learning how to do DEXA scans, I found out that my spine bone mineral density was minus 1.8. You know, this is when I was 30. You know, what do I do with that information? Well, I get a DEXA scan when I'm 50 years old. So my relative risk of fracture is higher compared to a 30-year-old, but my absolute risk of fracture is still relatively low. So it's a good question, and some of it has to do with resources and what you do with the information. So I may have missed the cutoffs for treatment in the spine and hip. 20% in the spine and 4% for the hip. Do you mind going over the difference between Z and T scores again? Sure. So we'll do it. We'll do it in some of the cases, but I will here. So T score is the bone mineral density, the number of standard deviations that your patient is away for someone at their peak bone mineral density. And so that's between ages 25 and 30. And so the reference population is generally NHANES. And so it looks at that reference population. So minus 2.5 is 2.5 standard deviations lower than the average person at their peak bone mineral density. The Z-score is the reference population is someone who is age matched, and it's age matched within a 5-year bin. So there's a little bit of play there, and someone who is race matched as well. So the caveat, and I'll get to this in one of the cases, the caveat is that we use, and this may seem weird, for T-scores, we use the young white female population regardless of who the patient is. And this is just so we can standardize across, and that's the T-score that the FRAX takes. And this is weird. You might have a black male that you're evaluating, but still his reference population for his T-score is going to be vis-a-vis the young white female population. So it seems weird, but it's just a way to standardize BMD across different populations. Now, another caveat here with these T-scores is that we're okay in the US, and NHANES is a good data set, but in other countries, it's unclear who the reference population is. So, you know, I have a mentee in Uganda where we're trying to figure out what the bone mineral density should be in people in Uganda. And it's really, there isn't a national database. And it turns out that the reference, the HIV negatives that we have, their bone mineral density is lower than African-American women. This is a young women study, African-American women of the same age. And so it's important to think about the reference populations. Okay. Easy to get coverage for DEXA for postmenopausal women. What about men over 50, diagnosed bone disorder for coverage or low testosterone? Yeah, so I think we're pretty good for coverage based on the NOF guidelines. And we have to realize that, you know, in all of medicine, you know, a lot of, you know, cardiovascular disease, hypertension, you know, women are very underrepresented in the trials, and there's a big, you know, gender gap here. It's the actual opposite in the osteoporosis world, that men aren't studied as often. And so it's important to know that about 1/3 of hip fractures occur in men. So I think there's general understanding that osteoporosis is also a disease of men, but you may still get some pushback from insurers. But you should, from the NOF guidelines, you know, I think you're pretty good in making a case for DEXAs, and Medicare seems to cover them. Let's see, when do you change from TDF to TAFT, abnormal DEXA or fracture, or routinely? Good question. So, so my practice, since I'm an endocrinologist, I get referrals from our HIV clinic, and I would, when I have, and I'll show you a case, when I have someone who has on TDF and has osteoporosis, or I also use age as a threshold. So someone, older people, you know, over postmenopausal women or men over 50, I think that change from TDF to TAF should be considered. You get about a 0.2 or a 0.3 median increase in your T-score from a switch from TDF to TAF. So it can pull, it pulls about, in a study that we did and presented at CROI a few years back, it pulls about 25% of people from the osteoporotic range into the osteopenia range. So it does have an effect, and it is a clinically significant effect. So you know, I would risk stratify. A lot of it is dependent on what's available and cost, and whether TDF is required, that the cost is less. For young people, the bone mineral density comes back. So I honestly don't think it's a huge risk of fracture. It's the people that older people, and I'm now in that older category. So people over 50, postmenopausal women. That's where I would really think about looking at their bones. There's also issues with weight gain, as we know, with the switch from TDF to TAF. So you're sort of juggling risks and benefits. Okay, could you review best use of screening for vitamin D deficiency based on race and time of the year? Great question. So, my view has changed quite a bit about vitamin D deficiency over the years. So I'm sort of a reformed vitamin D evangelist. So if you asked me this question 15 years ago, I would have said, oh, vitamin D, there's so much vitamin D deficiency. You should be screening for vitamin D. You should be treating for vitamin D deficiency. We have good ways to get vitamin D up, and we'll be doing the patient a lot of favors. And then, and I've contributed to this literature of looking at the relationship between vitamin D and various bad outcomes, and invariably low vitamin D is associated with all kinds of bad outcomes, including fracture. And so this led to a whole bunch of clinical trials where you randomize people to vitamin D or placebo, and these trials are still coming out. Most of them really don't show a big effect. And so the VITALS trial came out, didn't show an effect. There's been lots of meta-analyses of vitamin D supplementation in terms of fracture risk, maybe a modest effect. There actually are as many meta-analyses of these trials as the trials themselves. So it's a controversial area when that's the situation. So my general approach is to do universal supplementation in everyone, not do a lot of aggressive screening. I do screening in people who have osteoporosis for the reasons that I mentioned before, that you really want to get the vitamin D level up and up above 30. Before you start bisphosphonates, and you also want to identify people who may be at risk for osteomalacia. The issue of race and time of year is really important. I think that vitamin D deficiency means something completely different in people with darker skin. That really isn't well appreciated in the guidelines. And so if you look at say the Women's Health Initiative and the relationship between vitamin D and fractures and the general population of women, if you look at the white participants, the lower the vitamin D, the higher the risk of fracture. It was just the opposite in the African American women. The higher the vitamin D, the higher risk of fracture. So I think it's telling us something different. And when you give vitamin D back to people with darker skin, there's probably some catabolism that goes on so that you get a lower bump in their vitamin D levels. So I think that there's more nuanced approaches needed, but that's really not reflected in the guidelines. And then the time of the year is important. So there's about a 5 nanogram per deciliter difference between 5 to 10 between the summer vitamin D levels and the winter vitamin D levels. So you have to keep that in mind as you're thinking about this. And this is really only in people with lighter skin. People with darker skin, it's pretty flat. Okay, seems like it'd be difficult to obtain a second DEXA within a short period of time to remeasure it after repleting vitamin D. Yeah, I mean, I think you probably could do it within a year. I think that's a reasonable amount of time if the person does not have a fracture. If the person has a fracture, then the timeline needs to be compressed quite a bit. But you see these changes quite quickly, within the first 6 months, and by a year you'll see steady state. Do you comment on DEXA screening and advanced renal disease? Okay, so people with, so this is a big issue. We know that people with renal disease fracture. So people say I have a GFR that's less than 30, they fracture. But the problem is that there's a lot that might go into their fracture risk besides the typical thing of osteoporosis. So renal osteodystrophy is a complicated kind of thing. There's a low bone turnover state that you're worried about with renal osteodystrophy that obviously won't be impacted by anti-resorptives. And so for someone who's generally, we don't give bisphosphonates to people, and I'll have a case like this, who have a GFR less than 35. And but we can give denosumab. But if you get to a GFR in someone with, get to a osteoporosis in someone with a GFR that's less than 25 or less than 20, if you really only want to give medications if someone is fracturing, and in that situation, this is when a bone biopsy may be helpful. Okay, regardless of age, someone on ART for X number of years, who should be tested yearly, for example, 10 years, after 10 years on ART. Who should be tested early, sorry, misread that. Yeah, so there is a, people have been very treatment experienced kind of people, have seen a lot. And so, I work in the multi-center AIDS cohort study, and we have a lot of people, the study's been going on since 1984. And so men who were in that study have seen lots of uncontrolled viremia, lots of copy years there. They've seen lots of antiretroviral therapies. And so generally, this population, and they started the antiretroviral therapy at a low CD4 cell count. And so this is a group that's particularly at risk for fracture. So these highly treatment experienced kind of people, I would prioritize them high for treatment, for screening rather. So I think that is an important question. Can you adjust fracs for TBS? And I'll show you that in a second. You just basically press a button. So let's see. So 103, I'm going to get a hard stop at 110. So we're going to get kicked out. There are a couple things that I want to emphasize here from my cases. And so let us go to let's just go here. So this is actually someone that I had an audio call with this past week. So 75-year-old, longstanding HIV. He's one of these people who did not immunologically recover. So his CD4 cell count is always in the 200s or even less. He's on Bactrim prophylaxis. Undetectable viral load. Here's his antiretroviral regimen. He's got coronary disease. He's got bad cirrhosis, and they're thinking about liver transplant. He's got CKD with a low GFR. He's very frail. He's had multiple falls. He hasn't any fractures, which is good. He uses his walker. He's got some cognitive problems. He also, I won't get into the testosterone aspect too much. It's an interesting area. He's got low testosterone. But he had been on testosterone before and didn't really have any kind of symptomatic benefit at all. So here are his DEXA scan results. So in this lumbar spine, he's in the mild osteopenia range, femoral neck in the osteopenia range, also osteopenia in the total hip. And so when you put in his risk factors into fracs, you see that it's 8.5% for the 10-year risk for major osteoporotic fracture and 3.6. So neither of them really reached the threshold. And the question, the TBS question, so if you were to adjust for TBS, you would just press that value in fracs and you would get the TBS and you can put it in there. So, he doesn't reach the threshold. He's got osteopenia, but the problem with him is that he's really frail. And this is where the fracs doesn't really account for the person's overall fracture risk. So I'm really worried about this guy. He's frail, he's falling, and he's got lots of other problems. He does have CKD, which complicates things. And so here are the questions that I had, when I saw him on Thursday. So should he be started on testosterone for his bones? And in interest of time, I'll just sort of answer the questions as I thought of them. And the problem is that testosterone probably will improve his bone mineral density. There's never been a trial similar to the Women's Health Initiative with estrogen, large scale trial to look at fractures with testosterone. That's sort of ongoing now, or thinking being contemplated. So I wouldn't, and the fact that he had started it before and his cardiovascular risk, this is a whole nother talk about testosterone use in older men, but I'm shying away from testosterone to help his bones. What about bone-specific medications? Despite his fracs not reaching threshold, I'm worried about this guy. I think he's going to have a fracture. And so he does need bone-specific medication. The three things that I think about are anti-resorptive. or a anabolic. So anabolic would be teriparatide or abaloparatide. Generally, as I mentioned, you need to go with the anti-resorptive first. So of these, I generally do reclassed, so zoledronic acid, and not denosumab. And the main reason with the problem with denosumab in people with HIV is that there's a potential increased risk of of infection. And so in a guy whose CD4 cell count is in the 200s, I'm worried about that. And even though the guy's GFR is low and lower than you'd like in someone to give them zoledronic acid, I was weighing this on Thursday and I said, okay, I'm going to give zoledronic acid. It's cleared renally. I'll give him, instead of 5 milligrams, I'll give him 2.5 milligrams. And so that's what I did. And any other treatments, I think the fall risk, referring him to physical therapy is a really important strategy in addition to the calcium and the vitamin D. So 107, well, let me pause here. I don't want to really rush through it, to see if anyone has any questions, and I can do the second case quickly. Okay, so let's, this person that I saw in clinic, in my endocrine clinic for diabetes, no history of fracture. She was having falls secondary to foot drop because she's got neuropathy. She has a history of long-term TDF use. 5 months prior to when I saw her, she had switched to TAF. And this I wanted to show you. This isn't her report, but I wanted to show you what these reports look like. You want to look for the spine. You see the spinous processes. You're looking for whether or not the spine is tilted. You look for BMD that increases with each vertebral body. You look at the average for L1 through L4, assuming you don't have any abnormalities in one of the lumbar spine vertebral bodies. And then you look at the T-score and the Z-score. Importantly, down here, you'll notice that the T-score versus white female. So this is where you can tell from your DEXA report who the reference population is to generate your T-scores and your Z-scores. Then you say Z-scores versus white female. And then for the hip, what you're looking at is two values, the femoral neck and the total hip, and those are the most important values. The problem with the longitudinal DEXA scans is that the femoral neck is a little bit swirly in terms of positioning. So the femoral neck is quite good at a cross-sectional, but it's not so good on the longitudinal measurements. And so this is her values. So she had a T-score minus 4.3, so osteoporosis of the spine, osteoporosis of the femoral neck, and osteopenia of the total hip. So I gave her zoledronic acid and have treated her successively. And in addition, she got back. She is on the switch from TDF to TAF. She's had pretty good bone mineral density gains overall, but still not out of the osteoporosis range. And here in the osteopenia range. So this is a good illustration of the femoral neck being squirrely to positioning. So it says she had this giant increase in bone mineral density from 2017 to 2019. Then it went back to minus 2.2. This was probably a positioning error on the 5/30/19 DEXA scan. So when I saw her the other day, the question was whether or not to continue or to put her on a holiday. And because of her bone mineral density in her spine, the low bone density, I continued her zoledronic acid. If she was in less than minus 3.0, I probably would have given her a holiday. And so that was the question: should she continue on the zoledronic acid? And so last, I'm going to get the hook here. It's 110, but important questions. In general, are you okay using TAF in known osteoporosis? Should you switch to a non-TDF regimen? I'm pretty good in using TAF. It's an important question whether or not there is some residual bone effect with tenofovir alafenamide, but I feel pretty good with TAF in general. It's be interesting when we have, we now have dolutegravir 3TC, sort of a denuked regimen, whether or not that's associated with any improvements or nuke sparing regimens. How long is a holiday? It really depends on what what their bone mineral density does. So I follow their BMD every year to determine whether there's a drop in BMD. Generally, I consider a 5% drop in BMD something where I need to stop the holiday and do something else. And the second question about how frequently repeating, I do it yearly to look at people's bones over the years. So it's 1:11. I think we're going to get the hook. I'm going to type my email here. And if you have any questions, feel free to reach out. I'm happy to field clinical questions of any type. And then when you see my slides, if you look at the cases and you have questions about the cases, feel free to reach out and ask them. And thanks for your attention. Enjoy the rest of the conference, everyone.